Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is MCQ and Viva questions. So, in today's presentation, we will discuss mainly two main topics. One is how to manage the airway, and other is swelling of the pinna. So, you can get questions in both Viva and MCQ, and sometimes even in OSCE. So how to manage the airway? Whenever any question it appears before you, read the question carefully and see what they have asked. Then look out for the cues, uh, like what is the surrounding of the patient, in which setting the patient is, either in the hospital, in the house, outside, far from any medical facility. Then what is the quickest method to maintain the airway, and what are the long-term methods. So, like these are some sample questions which can come. A patient presented to emergency room with stridor or respiratory distress. So question can be asked, what is the quickest way to maintain the airway? The question can come, a patient is in the house, or he is in the picnic, or he is on picnic far from the developed area, in far flung area, away from any immediate medical attention area, and present suddenly develop any respiratory distress, stridor or gasping, then how will you maintain the airway? Again, question can come, a patient is in the hospital setting and need prolonged ventilation, so what is the best method to do so? And also have to read the question carefully to check, in any case of the stridor, whether intubation is possible in that patient or not possible. Like if a patient has a maxillary fracture or mandibular fracture, the mouth opening may not be there and endotracheal intubation may not be possible. Or there is a big tumor or growth of the larynx or base of tongue or any upper airway which is blocking the airway, it will definitely will not allow for the endotracheal tube to pass. So you have to read the question carefully and then have to give your answer. So if we look at different methods to maintain the airway, there are some basic maneuvers and techniques, then there are airway adjuncts and some advanced techniques. So the basic techniques or maneuver is head tilt and chin lift, jaw thrust, and the recovery position, which is semi-prone position or the comatose position, or best known as left lateral position. Then adjuncts, airway adjuncts are the oropharyngeal and the nasopharyngeal airways. And in advanced techniques becomes the endotracheal intubation, laryngeal mask airway, LMA, cricothyrotomy or cricothyroidotomy, and tracheostomy. So these are all different methods with which you can maintain the airway. Okay, so if a question asks what are different methods to maintain the airway, you have to start from basic techniques, airway adjuncts, then to the advanced techniques. So this is the basic maneuvers. You have to tilt the head backward, push the jaw upward, and open the mouth with the thumb downward. Because what happens when a patient lies flat, the main problem is tongue fallback, and this tongue fallback can cause death or respiratory distress. So with this simple maneuver, the tongue will become forward and the patient will able to breathe. So this is the way to open the jaw, head tilt, chin lift, and jaw thrust, moving the jaw upward and with thumbs opening the mouth. Then for the assisted devices, there, as I mentioned, two types of devices. One, the oropharyngeal airway, and second is the nasopharyngeal airway, meaning this is passed through the nose into the nasopharynx. and this pass through the mouth. These are of different sizes from pediatric to adult size. So how to measure the size? You take the oropharyngeal airway. This is rigid and the nasopharyngeal is rubber soft. So the size should be from the angle of mouth up till the ear lobe. There are two ways to insert. You invert the direction, take it inside and then rotate it 180 degree and it should bypass the base of tongue. Or you depress the tongue and directly insert it. Same for the nasopharyngeal airway. It should extend, the size should extend from the tip of the nose up till the ear lobule. And you lubricate it and then pass it inside along the floor. Don't try to go up. You have to put it along the floor, so it will go like this till its opening, which stays at the nostril. So these are the other methods, advanced techniques, including the LMA, laryngeal mask airway, and this is the endotracheal tube with cuff. This is cuff. There are certain endotracheal tubes which are without cuff even. So for laryngeal mask airway, you just need to tilt the head. You can, if the mouth opening is not there, you can with your thumb and index finger pull down the chin and just insert it inside. So it will go deep and this thing comes around here. So it will, these are supraglottic devices. It will not bypass the vocal cords like in endotracheal intubation, but it stays above that. But a very useful tool. For endotracheal intubation, we need the laryngoscope. It is not possible to insert the endotracheal tube without laryngoscope. So this is the quickest way for maintaining the airway in hospital setting, but in emergency, not in OPD, in emergency or operating room. So the other two methods, which are cricothyroidotomy and tracheostomy. So for that, uh, this is the patient head end, this is the foot end. So we marks the marking. This is the chin. This becomes the thyroid cartilage. Just underneath will be the cricoid cartilage, and then this is the sternal notch. So for cricothyroidotomy, it is done on the cricothyroid membrane. So this method is the quickest method when the patient is not in hospital setting or far from the hospital setting, because here only the membrane lies and beneath the membrane or underneath the membrane is the airway. So you can pierce this with any sharp object and maintain the airway. Mostly which you have seen in the movies, they show that they pass a straw or anything inside the air column to maintain the airway. That is not tracheostomy, that is basically cricothyroidotomy. For tracheostomy is a full-fledged procedure which needs special equipment, proper lighting, proper positioning. Without proper positioning and light, you cannot perform tracheostomy because there are muscles, fascia, skin, fascia, muscles, thyroid isthmus, and underneath that the trachea comes. So if any injury to any of these structures, there will be lot of bleeding there, and then it will not be possible to reach the airway. So we have to do this procedure with proper setting in operation room or even at bedside, but with all proper equipment available. Okay, so this is a scene from a movie in which what happened with this patient, that he suffered a blow on the neck, the upper part of a neck, with a metal rod. So it is a blunt trauma causing injury to the upper neck, meaning the larynx is involved. So the patient, after suffering from injury, develop breathing difficulty or respiratory distress, as the larynx it gets collapsed due to trauma. So what is the emergency measure is to give incision, and as the scene is in a bus, So the straw was there. So the person uh, who do the procedure pass the straw, so the patient is able to breathe now. As this area it is blocked, so now the breathing is redeveloped from below, as it was not going up due to the collapsing of the larynx. So with this urgent procedure, his breathing is restored. So this is the tracheostomy tube, this is the outer tube, inner tube, this is the cannula, this is the stellate when we need to close, and the tracheostomy tube has to be secured with the bands around the neck. So let us see again. A patient presented to emergency room with stridor. What is the quickest way to maintain the airway? And the answer to this question is endotracheal intubation. Second is a patient is far from hospital, depending upon what the scenario will be. But main idea is the patient is not close to any medical facility and have respiratory distress or stridor. So how to maintain the airway? So in these cases, you have to perform cricothyroidotomy. It can be done with a fork, with a ballpoint, any sharp object, just pierce forcefully inside. Then any patient in hospital setting needing prolonged ventilation, the best method is tracheostomy. So any patient who is or people who are on ventilator and need prolonged ventilations, they have to we have to convert it into tracheostomy. Okay, for cricothyroidotomy also, remember that whenever cricothyroidotomy is performed, it should always and always converted into tracheostomy, and we close the incision of the cricothyroidotomy because this is only for emergency purposes. Once airway is maintained and patient has reached to the hospital, then we convert it into proper tracheostomy and close the this incision which is on the cricothyroid membrane. One main reason is because the cricoid cartilage, it is a complete cartilage, so any incision in that area, that's why we also avoid incising between the first tracheal ring, first and second tracheal ring, or above first tracheal ring, incision for tracheostomy, because cricoid cartilage is a complete ring cartilage and it will lead to perichondritis and subglottic stenosis. So this has to be converted into proper tracheostomy. So in the same scenario, question can be asked in Viva, where what are the different ways to examine the larynx or the airway. So I have given full presentation on that. This is the link. You can search for that. Indirect laryngoscopy is one method, but there are 5-6 methods with which we are able to visualize the larynx or airway. So you should know all those methods. At least 3-4 you should be able to tell in the Viva. Now the second question is swelling of the pinna. So swelling of the pinna, it can be 2-3 conditions in which there is swelling of the pinna. So first is the perichondritis, then it can be oral hematoma or seroma. So perichondritis is basically an infection and inflammation of the perichondrium, which is the covering of the over the cartilage. So once there is swelling of that area, it will known as perichondritis. But if there is collection of blood between the perichondrium and the cartilage, then it will be oral hematoma and usually occur following blunt trauma. While seroma is the clear straw colored serous fluid which is present again under the perichondrium and above between the perichondrium and the cartilage. So both oral hematoma and seroma appear similar, uh, and once you aspirate, then you will be clearly able to differentiate whether it's a pure hematoma or it's a seroma, because both appears as a swollen lump. Now this, if you see, this is only the swelling of the pinna without any collection underneath. So, and if you're able to visualize the normal grooves, they are disappearing. So that's why the treatment is emergency. All these three conditions, they are emergency, and they need or they require immediate intervention, because once these grooves they lost, then the ear may become deformed. This is, if you see, something is underneath the skin as it is swollen too much. So this is oral hematoma. Okay, and it will continue to expand and involve the whole pinna. Uh, if you search on the net, they can write it as cauliflower ear, but this is not cauliflower ear. Cauliflower ear is its end result. If this blood is becomes formed there and ear become deformed altogether, that is cauliflower. This is not cauliflower. This is oral hematoma, and cauliflower is its complication. And this, you see, this is seroma. This again collection here, this collection here, this is collection here. This is seroma. So the same auricular hematoma is blood collection underneath the ear skin between oral cartilage and perichondrium, and usually occur due to blunt trauma. So many sports like wrestling, boxing, rugby, where there is blunt trauma again and again, they have many of the players, they have the deformed ear. So treatment is, it required urgent evacuation. If it is only swelling, then I will tell you little later what we do. In those conditions, let me tell you now, we have to put wicks along the ear grooves and do pressure dressing. If it is small collection, then only needle aspiration and pressure dressing will suffice. But if it is large, collection is large, then we need to perform incision and drainage. Either after that you can do pressure dressing or you can stitch buttons, because dressing on the ear is very difficult and it's not easy to maintain that. Like if you see in this picture, there is collection here. So on aspiration, this is the blood, 2 cc is removed and it depressed, and with treatment, medical treatment and dressing, pressure dressing, it has resolved. So for as I mentioned in previous slide, dressing, wick dressing along the groove. So these are different sizes of wicks which you made. Then you have to dip it in the pyodine. When we dip this in the pyodine, then we place it along the ear grooves, like here around the helix, here along the scaphoid Simba concha, here along the triangular fossa and the scaphoid fossa. So all this you put the pyodine dip. This is dry, but you have to put the pyodine dipped wicks. Then after this, you put a gauze piece above it. Then as we have to do the dressing, if we just do dressing like this, it will come on the eye. So we put one string of gauze piece here and do the dressing with crepe bandage like this, and this string will tie it so that the dressing will not fall on the eye. So this is known as mastoid dressing or the pressure dressing, or pagdi dressing you can also call it. So this is the way to do dressing. We do this dressing even after mastoid surgeries, ear surgeries, and for pressure dressing, because just applying tape here, it will not do any it will not apply any pressure on the ear. It will just covering it. So to apply the pressure, we have to do this mastoid dressing. This, as I showed, it is the blood collection. So we need to give incision either here or here, as it is involving here the Simba concha, scaphoid fossa, and the markings are filling up. So the incision is made, and this bit I'm talking about the buttons. So we stitch the buttons, so in front also and on the back, or either you do mattress or quilting suturing through and through. So with those stitch, it will apply pressure and prevent the reaccumulation. And these are the results. But still, if you visualize this anti-helix, lower groove is there, but upper groove it has now not appearing normally for in this picture. So, but if we have not performed any of the procedure, then all of these grooves will be disappeared. So, like I'm talking about in wrestling, this is Brock Lesnar, MMA fighter and the wrestler. So, if you look closely his ear, so this because of repeated trauma has become deformed, and the blood which is collected and not evacuated in time, it has made into fibrous strands, and now this is the cauliflower ear. This condition, which is the end result, is the cauliflower ear. Like here, the blood is there, but it is not evacuated, and now it has led to deformity, and all the grooves they are finished. So this is for this presentation, and inshallah we'll come again with some other questions. Thank you.